Welcome to everyone here in person and to those online. I'm Dr. Heather Strachan and I'm a past chair of BCS Health and Care Scotland and IMEA International Medical Informatics Nursing Informatics Group. And I'm delighted to be introducing this year's Derek Hoy Memorial Lecture, which is now in its 11th year. And I want to tell you a little bit about Derek, for those that didn't know him. Derek was a nurse, he was an informatician, and he was a leader. And I'd like to reflect on those qualities of leadership that he brought to informatics, which was so important to all of us today. One of Derek's key qualities was his intellectual agility. He understood the place informatics has in all its broad variety of areas, from building blocks such as healthcare terminology, through to integration of knowledge management, into decision-making processes of clinicians, through to the analysis of information to improve the quality of healthcare and support data-driven decisions. His work covered a huge range, from electronic health records and care summaries, mobile technology, self-help information systems, clinical templates, information standards, and open source, all of which have laid the foundations for the current work that we are working towards in terms of digital transformation today. Derek had vision and passion. Early in his career, he received a Florence Nightingale Foundation Scholarship, and he visited the USA, and he learnt more in-depth knowledge about the possibility informatics could have in terms of improving the quality of healthcare. He was always 10 steps ahead of everybody else. Derek was a communicator. He was able to communicate that vision persuasively through his networks both internationally and nationally. Nationally, he did many projects for the Scottish Government, but also as a group member of the BCS Health and Care Scotland. And internationally, he worked with the European Foundation of Medical Informatics, Federation of Medical Informatics, and the International Medical Informatics Association. Indeed, Derek was an inexhaustible source of energy and inspiration. Derek understood the importance of change management. He was involved in many educational initiatives, particularly at Glasgow Caledonian University, and as part of the European-funded Nightingale project, where he developed resources and materials to help informatics for nursing students all over Europe. And he shared his knowledge with other nurse informaticians at many summer schools. There was a lighter side to Derek too. He was an accomplished fiddle player and a whisky connoisseur, hence the venue today. He had a great sense of humour, and he is greatly missed by his family, many friends and colleagues. But I am actually delighted to welcome one of those colleagues, Anne-Christine Ruteger, who shares a lot of the same skills and interests Derek envisioned many years ago. She is currently chair to the International Medical Informatics Association Nursing Informatics Group, and Anne has an MA in Nursing Science and a PhD from Oslo University. She has extensive clinical research, education and management experience. Anne is also Managing Director to VAR Healthcare. VAR is a system developed by nurses for nurses and has evolved under her leadership from an encyclopedia of procedures to a system for evidence-based documentation practice, including knowledge support, process support, and decision support for clinicians. Anne-Christine is committed to promoting quality, structure, and continuity in nursing and nursing documentation. She has over 20 years' experience in nursing informatics, and amongst other accolades, she has had an active role in the translation and development of healthcare terminologies and contributed to several research articles and book chapters. Anne-Christine's lecture will focus on nursing informatics lessons learnt from a Scandinavian perspective. It will also touch on the important elements required to realise the goal of safe clinical practice where knowledge, professionalism and occupational pride are key focus, with examples from Ann-Kristen's own experience. She will reflect on her international experience and will provide us with a demonstration of a clinical decision support system for nurses, used by nurses for more than 20 years in Norway, and will provide a vision of the near future. And if anybody has any questions, either in the audience or online, please add that to the chat and we'll take questions afterwards. Welcome, Ann-Kristen.
Thank you so much. And thank you for the very nice introduction. I'm honored to be here today in the memory of Derek Hoy. I had the pleasure to meet Derek when I was a PhD student. I was still in the process, and I had one of my first presentations. And as a PhD student, you were nervous, of course, because you felt that everyone was critically reviewing what you were saying and everything. And I remember Derek was at the back end. He was one of the few people there because as a student, you're not so popular maybe or exciting, but he came up afterwards and had a lot of questions, was very engaged. And sometimes you feel like researchers are obliged to do that, but that was for real. That was at the EMEA-NI Congress in Helsinki in Finland, 2009. He also tweeted from that session, and I realized that later, and then that was the first time I was tweeted. So I still remember that. We also found out through our speeches that he had been collaborating with my advisor, Professor Cornelia Ruland, and they actually had written a book and a paper together, which was titled Computer Technology and Nursing, Who Sets the Terms? And that was way back to 1993. And as you said, Heather, he was way in front of all the others. Of course, I knew Derek from papers. I had read many of his papers. I had been to many lectures that he and his colleague Nick Hardiker held. And what strikes me is exactly what you said as well. There's so much seriousness in research, and of course it is serious. It should be serious. But they had the skills to actually make a talk very interesting and funny. And that was so amusing and relaxing compared to other places that I've been, and I learned a lot of that. The last time I met Derek Hoy, so it was a short period compared to your experiences. That was actually the year after at MedInfo in South Africa in 2010. And then I had the pleasure to join him and several others at dinner. I had an idea to go to a place where what was recommended, and that was Mother Africa, where you're supposed to eat not the big five from Africa, but it was definitely about meat. And we had lots of fun that evening because one of them joining us was a vegetarian, and that was very much laughter. So, let's see. So the agenda today is, oopsie, that was the wrong way. Is to share my thoughts and help shaping the future, taking account of Derek's legacy. And as you said, we have a lot of common touch points, and that he inspired me to go in those directions. He was one of many who inspired me to go in that directions. But I want to start out with my entrance into nursing informatics, because it's many ways into nursing informatics. And for me, it was EMEA-NI. I was early introduced into EMEA-NI. And I did a summary in there, look at the history. It started already in 1966 with the first interest of computing in nursing. That's the year I was born, so it's some few years ago. And the International Medical Informatics Association the year after was established. And we see that Nursing Informatics Working Group was established in 1982, only a few years after the independent organization of medical informatics. So nurses have always been pioneers, but also within informatics. It takes a while until you get on the list of mesh terms, and we have just experienced that in 2005 was the year of nursing informatics as a mesh term. So it slowly goes forward. EMEA-NI is now an independent group within EMEA used to be a working group, used to be a special interest group, but now it's an independent group. And one of the reasons for that is the hard work that many nurse informaticians has put down in the international society in collaboration within EMEA. And there's a lot of great work been going on, and the Working Group of the Year award has been provided for the groups 3 times. For me, it started in the pediatric and adolescence clinics. This was the first unit and hospital to start using care plans in Norway. It was also the first unit and hospital who had a research nurse working with research 100% in practice. Kari Gloppestad, she is still one of the most famous nurses within pediatrics. She has her theories within kangaroo care, lactation in preborn babies, that still is highly valued and used. This was also the first unit and hospital that started to systematically collecting data on nursing resources and nursing quality. And we wrote reports every year, and this was the only unit in that hospital that got new resources every year based on the reports. So the other units at the hospital, they were first very envious, and they said, we also want more resources, but then they really understood we need to work more systematically on reporting and data. So with that solid background and working place, my curiosity and the foundation for taking the next steps rose. Also, the environment was very oriented towards knowledge. So the doctors, the nurses, we always challenged each other every day at work. Why are you doing that? Why are you collecting that information about the patient? What does that mean? That was a daily challenge. It was hard being a newly educated nurse there, and but we learned so much. So where did it all start in Norway? It started with the digitalization in connection with increased requirements for coordination and quality assurance of the health services in 2000 and 2001. That was the time for the new health laws. Nurses became more independent with higher responsibility. We had always been doing nursing documentation, but this time it was anchored in the law. And also the health and quality reform was introduced. And the health authorities, they required and demanded an increased use of ICT. The first electronic patient record system actually came in 1991 in one of the hospitals down south. However, the real introduction of electronic patient record systems was in the early 2000s in connection with the law changes. In the beginning, people couldn't see any big differences because it was actually electricity on paper. But the accessibility of the journals, that was really a revolution. So that was the first big step in Norway. And they did a decision that all trusts or hospitals in Norway and regions, they decided on one system, that was the Siemens DocuLive, and they decided on a framework for nursing documentation, which was the WIPS model. I'll show you a little bit more about that. The good thing that they did in the beginning, they involved the nurses to further form and adjust the electronic patient record system. And also doctors, of course. And the use of the WIPS model, that was quite new for us. We had been working systematically and structured at the children's department with documentation, but this was a model made in Sweden of the Swedish nursing researchers that actually covered the whole nursing process or the whole documentation process from the nursing anamnesis to the information exchange, and with the core elements of nursing diagnosis, goals, and nursing interventions. And the good thing about this was that they used actually the same terms as the doctors did, just to show that what is our responsibility compared to them, and we had the same language to talk together. An anamnesis from a nursing perspective is not the same, but it's completing each other. That was the idea. However, it was not without challenges. They did not use the whole framework from the vendors' parts because they thought it was too big, too much information. So the only thing they did was actually to implement the first 2 steps of the process. We had a lot of keywords, and the idea was to actually document free text within those keywords. Then you can use the keywords to search and get an overview. But building or adjusting system to the practice of today, what we're actually doing, that is not good systems. That is not good support for the nurses. So we started to wonder about, yes, but this is also important. This is what we used to work with in the children's department, even if not all hospitals and units did that. And we discovered that we were thinking in an analog way, electricity on paper. So what happened actually clinically when we started out? Nurses and nursing became visible. It was easy for the doctors to see what the nurses was writing, and they said, what is all this bullshit? What are you doing actually? And when we started to talk about nursing diagnosis, it was a big fight because diagnostics, that was only the doctor's tasks. So we had a lot of discussions. What is actually good nursing? We asked ourselves. How are we documenting, and is this the right way? Do we need nursing diagnosis? And we discovered it was a need to revitalize the nursing process, because when we went through it, it was something that we learned in school, but we didn't talk about it, we didn't use it in clinical practice. So we had to take a step back and start educating nurses. We were a little core of nurses working with that topic. We engaged in all the informatics conferences that we could join. I took a course within nursing terminologies at the just a minute, at the I can't remember the name, the University of Colorado, Denver Health Sciences Center, and my teachers were Nick Hardiker and Diane Skiba, and I learned a lot of terminologies. So continue educating yourself. I think that is one of the big things here. What we actually did when we learned that, well, we can use terminologies to help the nurses more in the diagnostics, in setting goals, in setting up good interventions. There was a lot to choose between. So what we did was actually to take a model from James Semino and evaluated all the available nursing terminologies. And we ended up with ICMP. 1 year after, the Norwegian Nurses Organization did the same, because they wanted to work politically with terminologies and had visions for more digital documentation. I also went into the Nordic VIPS group, who was working with the VIPS model, and we did a mapping to the ISO 18104, and also found that there was a good match, and we could also find further development of the VIPS model. But when we went discussing with the engineers and the developers, they continuously asked us, how are your working processes? And it was so easy to describe, but they were going down into depth, and they actually challenged us, and they said, does it have to be this way? So slowly we started to change from an analog to a digital thinking. And for me, just shortly, won't spend a lot of time on this, it was all about nursing diagnosis. What are the nurses' responsibilities? And through studies, reflections, discussions, these 3 areas was very clear. It was described in the process. Nurses' responsibility is to help solving the problems of the patients, help to prevent the risks. And Ingrid Torell Ekestrand, one of the professors behind the VIPS model, she always said that this is exactly where the nurses become visible, because the problems, the patient can feel the problems, the doctors see the problems, everyone around can see them, but the risks, you can't see them before they turn into problems. So that is where the high quality of nursing is visible. And we found that we didn't document so much the preventing perspective in nursing. Another type of call it diagnosis is the resources of the patients, strengthening and supporting those. That is also an important part of nursing, to be able to get to wellness and health. And for me, that was a natural, because I was working with children. And for children, it was always a main focus on the normal development, the disease was not the main focus necessarily, even when the child was in-house. But I was wondering, why don't they focus more on that also on adults? So that was the area I wanted to go into. I wanted to see the perspective. I went into Center for Shared Decision Making and under the leadership of Professor Cornelia Ruland, and wanted to actually fulfill her research perspective, which was focusing on problems, signs and symptoms. And I wanted to take that perspective and see how this could be merged together in her work. So I ended up with my PhD student study conceptualizing health assets in a nursing context, and I did a synthesis of findings from multiple perspectives, from content analysis of health assets as a concept, and I did qualitative studies within the cancer care setting, interviewing patients, nurses, and I did document analysis of the electronic patient record system, and I did a mapping to ICMP, and I found that ICMP, which actually consists of the big nursing classifications, was very problem-oriented and had very little terms covering that perspective. But, so this is just a model that I ended up with. It's a model to describe, and the idea was to describe what are the terms and the descriptions of health assets. And the idea was to use that in the further steps and maybe also find interventions or strategies to follow up on it. However, I was captured in VAR Healthcare because it was named PPS, Practical Procedures in Nursing, at that time. They needed someone to step in a vacancy, and they asked me, could you do that for half a year? And I needed some more money to finish my PhD. So I said, yes, sure. And I discovered that this is very interesting because here we have a digital tool for nurses consisting of procedures, but I saw that the procedures actually was interventions connected with nursing diagnosis and outcomes, but they didn't call it that. And for me, this was kind of a Kinder egg. Nursing quality and research into practice, digitalization, and nursing documentation. So what was PPS? What was VAR Healthcare at that time? The background for the development was that the hospitals, they developed their own procedures. However, they varied across the settings, so they could build up 50 procedures in one and the same hospital, but they were different. Why is that? How do we get to good outcomes? It was very resource demanding, so there's taking some nurses out of clinical practice, making them was a lot of work, and it was hard to keep them up to date, and they lacked evidence. Also, they saw that the documentation was time consuming and lacked quality, and were thinking that this is actually two sides of the same coin. Also, we saw that it was poor coordination and communication between units across hospital and primary care, primary and secondary care. So that fit well with the government's requirement. So they started out a project in 2001 to 2003 to digitalize the procedure handbook to make it more available. And under the way, the Norwegian Nurses Organization took ownership because they wanted to use this system as a foundation for health policy from their side and to make nurses visible and show them actually that the simplest nursing tasks, nursing procedures actually are quite complex. What is going on in the head of the nurses at the same time as you actually perform it? So this spread out. It was a system that nurses just said, we need this system. So within a few years, it was in use in nursing education, in district nursing and elderly care, as well as in hospitals. And today, it's only like a couple of handful municipalities and hospitals that don't use it, and it's all over in education. After a while, the Norwegian Nurses Organization had built up actually a strong organization. They couldn't own it anymore because it turned into business. They needed more investors to actually be able to further develop the technology because that is costly. So they sold us out to one of the biggest publishing houses in Norway, Cappelen Damm. And after that, the investment made us, put us in a position where we could actually take the step further with the digitalization. So we continued working on both the technology side as well as the content side. In the beginning, it was all about content. It was all about knowledge support. But we wanted to take the step further to also work more on the technology side. And today it is a decision support tool. Yeah, don't have to say much more about that maybe. And I want to show you how that was looking, and can be looking in the future. So this was the first version, or actually the second version. But as you can see, it was quite advanced at that time, and that was in 2005, this version. Lot of content, but they used actually technology very well. It was a lot of internal relations, and we already in 2005 had integration with electronic patient record systems. So all the content, all the procedure has a unique URL, and they use that URL with hyperlinks between the systems. So we have been using that integrated in an electronic patient record system since 2005 in Norway. But content is not enough, and technology is really, really needed. And when I heard Walter Siremius, who is the professor working with RN Forecast in Europe, presenting the RN Forecast studies results, he used an argument that based on brain research and based on psychology, we know that the nurses and everyone actually knows only half of what we should know, because the development is going so rapidly. And out of that half, we forget half of what we know. That's just psychology. And we perform only half of what we remember. So what actually could have been 100% implemented in clinical practice, we only perform just a tiny, not exactly, but around 12.5%. So that's why we need e-health, he said. We need systems that help us to keep up to date with the knowledge. We need system that helps us to remember, and we need system that helps us to implement that knowledge. And that was, when I saw that, it was, he's talking about healthcare actually. And this is decision support. So now I will go into the system just to show you shortly how it looks today. If I can just, so, sorry, I have to stand at the back here. So this is the front page. It consists of procedures and rationales. I will just give you a short peek. You can titrate yourself down in the tree and categories of procedures, for example, and that is based on basic needs, categorized by basic needs. And if you go into nutrition, for example, and go into administrating parenteral nutrition, you see that you can go to the PICC line, for example, disconnecting PICC line. Here you see when was this procedure last updated, and that was the 20th of June this year. We have a system of changes, a grading of changes that goes from 0 to 4. 0, like in this case, means that there is no new evidence, there is no new knowledge, but you can still rely on this procedure, so you know that this is safe to use. 3 and 4 is the top score, in a way. That means that the performance has changed based on new knowledge and new research. So it comes with a yellow label, and that is a signal, even to me as an experienced nurse, have been doing this several times. Normally I would just say, I know this, I know how it is. But now I need to read to be up to date. You also have the hygienic principle as the basics of everything. We know that hygiene is the #1 causes of mistakes, deaths, and so on. This is really, really a trouble that we have had since the days of Florence Nightingale. That is the information that the nurses need to have before doing anything in clinical practice. That's why we have collected it on the top level. And you easily see this is an aseptic non-touch procedure. You can click on it and get information, but you can also see the other infection control procedure that is actually interwoven or is integrated into the same flow. But we don't describe it continuously through because we want to keep the overview. This is something that the nurses just know. You have to clean your hands before and after every task, etc., etc. How do you put on your gloves, and so on. And then the rest of the steps comes, because this system is used both by students, or you don't actually, in situations you might be standing in that you haven't done for many, many years and you need more information. but you can also, as an experienced nurse, get a full overview. So we have divided the text in 3 steps. And here you see the main steps, and you can open one and one, or you can open all of the steps to see more information underneath, and even open a 3rd level of text with the rationale. So for example, if you are doing this together with a student and you are explaining more than normally, this is a good support in that situation. You can use it also to explain to patients and so on what is going on. It's a lot of illustrations, animations like here. You can play it off parallel with the text or in a big screen. And every time the text changes based on new knowledge, we also change the illustrations. And these illustrations we have collaborated with since the beginning of the development 20 years ago with Kari Toverud. She's one of 4 in Europe with a master's degree in medical illustration. So this is high-level knowledge. And as you can see, as part of the procedure, we also have the indications and desired outcomes mapped to ICMP, or now SNOMED CT, to help out in the nursing process, in the documentation process, because we know that putting up nursing diagnosis is the most difficult thing that nurses actually do in the documentation process. That's a lot of research uncovering that, and also the desired outcomes or goals connected to it. We also have media, so you can watch the elements alone. But also part of the template of the procedures is also the observations that the nurses are doing when they are performing this procedure. So what is actually going on in the head of the nurse parallel with what she's actually performing? That is quite advanced. When you click on it, you see several elements here, but also the information that you're supposed to provide with the procedure. So just like this is maybe a more complex procedure, but even if it was showering a patient, you could see that it's not only about showering, it's what the nurses is actually thinking of when it comes to risks, when it comes to observing, are there any infections going on, and so on and so on. So this actually shows the complexity, but in a simple manner, because it's easy to move between those elements in the system. The knowledge base behind it, with reference list, evidence-based summaries, with links when it's available online, with research articles, books to cover up for the practical perspectives, and also the legal content when that is available for it. And short summaries of text to describe why is the procedure described this way, the rationale for it, with mouse over in text for the references, and short text. It could be illustrations and animation here as well. That was just a short peek into the system. And based on that, it is one system for the whole continuum of care. And I think that is, if we want to work evidence-based, the evidence should be the basics for what we're doing if we're doing the same things. And we have proven through more than 20 years that it is possible, because it is used all over wherever the patient is, and the patient is more in focus in a system like this. It's used in education, it's used in patient care and treatment, it's used in competency development, and it's used in research and development, because we are doing those research summaries. It's easy to see where the gap is, easy to start out in further development here. We have integrations with quality management system, documentation system, and learning platform in those working processes where nurses are working. And I think that is one of the requirements for clinical decision support tools to end up there. And this is just a sum up. I don't know how I'm about time, but I'm fine. The electronic patient record system is the main support source for the nurses. So that's why we need the integration into a system like that. It requires structures, it requires standards, it requires detailed clinical models to do analysis and use the content. And in a detailed clinical data model, the content consists of data elements, relationships, structures, and codes. And it also consists of the scientific evidence, clinical practical knowledge, which we have included in VAR to be ready for good integrations. Also, we need standards, so terminology systems needs to be there, and we know that reference terminology systems is the terminology models to be used. That's why we chose ICMP in the beginning and got over now to SNOMED CT. but we're also using standards for the way we built up VAR. Because we have used standards, because we have thought about structure and systems, we are able to actually be at the point of decision support tool for tomorrow. And what's important that I also read here, and Willem Kusen is one of the researchers that really have done a lot in this field. And the flow of information between electronic patient record system and a clinical decision support system can go both ways. But it seems in the research that they have been focusing only on collecting data from the patient journal system and trying to build decision support tool on that information. I believe that we still are not at the point that these data are good enough because we are not structured enough in collecting that data. And I believe that the other way around that we are doing now, having a solid system where we know this is supposed to be done based on newest research, we will get better data and better analysis and better outcomes out of the research in the next steps. I have seen too many electronic patient record systems that have tried to implement knowledge, but it's not good enough. So it can't be used. And it's not up to date. So our idea has been for many years now, and we are seeing the first electronic patient record systems developing the next generation of support for nurses, but also for doctors. So let's imagine that you're a nurse, you use your electronic patient record system, and you are in a situation, you have a patient with dizziness. I didn't show you that in the system. You search, and back end, the search is pointing onto VAR Healthcare, and the search is running. The only thing that the nurse sees is the metadata that comes back to the journal system. That could be, like you saw here, the title of the procedure, the degree of change. This is new, sorry about that, that's Norwegian. For example, grade 4. Blood glucose monitoring, grade 4, but that was on the 21st of August, say 2023, and you know that, okay, I have read that, so you don't have to click on it because you know how to perform it as an expert. But if it's quite new, you say, oh my God, I need to read this to be up to date. So you get a signal right away in the journal system, so you know that you have to click it. And then you can have the connecting nursing diagnosis and outcomes, and you just click what is actual for this patient. And then you have all the core elements automatically stored in the journal system, with one click or a few more clicks from a problem to the solution. There has been research on clinical decision support, and there's been summaries of research on that point. And most research has been done in the medical field and not in nursing. Most clinical decision supports in nursing is in the acute care setting and based on single clinical conditions. No statistical significance of improvement of diagnostic support has been found in studies where nurses have been included, and there's little evidence to cost effectiveness in medicine and nursing. This means we need more research in this area. We need better systems maybe to get good outcomes. We did together with my colleague Bente Christensen, we wrote a chapter in the new nursing informatics book on health informatics, interprofessional, a global perspective about decision support, the technology and art of providing support where the clinician needs it. So more information can be found there. But what they say, what the research says is effective in clinical practice. There are 4 characteristics. That is, it has to be automatically available in the clinical workflow. Support should be given at the right time and place of the decision. However, there is an alert, I would say tiredness. So we know that too much alerts, it's not good. Practical advices and references are provided in the system, and the system is, of course, computer-based. It should be natural. So, a solid academic and professional foundation is the basic on which the technology is intended to support. There has been too many examples where engineers have built systems, they have listened to the nurses, but they have built a system around the nurses' analog thinking. For example, when a journal system built up a list over stool episodes for the whole bunch of patients in one elderly home. I mean, why do you need that? That has nothing to do with the nursing process. So, learn from your colleagues, collaborate with them and challenge them, the experts as well as your nearest colleagues. Be brave. Use your critical analysis and learn from the mistakes as well. Think out of the box. Don't follow the stream necessarily. Do not give up on your ideas and knowledge. I fought and fought with my team because they didn't understand ICMP. They didn't see how does this help us. But when we made it, when I just pushed it through, I tried to teach them, and I said, we'll just do this, and we can get back again if it doesn't help, if you don't see the point when it's ready. And now they say, oh my God, I'm so glad that you were so stubborn, that you wanted to build this, because now they see it when it works. And I think that is the core of nursing informatics. Use your knowledge, strengthen your knowledge, understand nursing informatics, because that is something different. And you have to twist your brain and think upside down sometimes. So what is the future of nursing informatics? Well, I have leaned onto one of the latest summaries and research in the area. And they conclude with there are opportunities for nurses to transform their role when you implement also and think about computing. The nurses' traditional patient and family advocacy role will remain important. And I would say not only that, but the coordination of care and the foundation of nursing still is important. And because the healthcare ecosystem changes so rapidly, it demands involvement from the nurses in all areas of healthcare, in research, in design, in adoption and use of digital technologies, implementation, management, change management, and so on. And the normalization of technology into the nursing role will require new knowledge and skills. We need to implement nursing informatics as a natural part of the education, of the further education. We have been talking about this for years and years. And first, like 2 years ago, we implemented it in curriculum in Norway. So it takes a while. So you have to be stubborn. And also will affect the relationship between nurses and between nurses and other like patients and technicians and so on. And that's good to see that we have more and more nurses in CNIO positions, that England has built up a good system of that. However, that is not enough. You also need the normal nurses on the floor to understand and use technology. It has to be an integrated part of our education and practice. So what are the future when it comes to the topics within nursing informatics? So Booth, Sturdwick and McBride et al. In 2021 did a summary here, and they made a list. AI and big data, obviously needed and already implemented in many ways. Also in Vard Healthcare we use that for the search engine for new research, and that has helped us a lot, because now we get more hits that can be used. We avoid duplications and so on. Automatization technologies like robotics, drones, assisted living technologies or smart homes technology. Clinical decision support system obviously needs more development and will be part of our everyday life. E-health solutions, electronic patient record systems, mobile health, telehealth. And telehealth was really, really important during COVID. Because Vard Healthcare was so spread out, we could collaborate with the authorities in changing and developing procedures that was needed in this situation very rapidly into the system, spread out at once to the whole healthcare in Norway. So, and also it was good because the schools that couldn't have the students in-house could use Vard Healthcare as a foundation for the telehealth education. personalized and precision healthcare, social media and online information, and virtual and augmented reality. But this is not possible if the foundation is not there. So, thank you so much. Are there any questions?
No, thank you.
Do we have any questions online? No? Okay.
Hi, my name is Sharon Levy. I'm part of the BCS Health and Care Scotland, but also the Nursing Informatics BCS Nursing Specialist Group. And I'm looking forward to seeing you and your work in the NI 2024 in Manchester.
Yeah, we'll definitely be there with it.
Good. Fantastic talk. Thank you very much. Just wondering, and there's lots to reflect on the journey you showcased here, the fact that you said to us that we need to be brave, we need to be persistent, we need to have the strength to know that we're doing the right thing, but it's difficult.
Yeah.
How do you explain to nurses who are turning around and saying, look, I don't have time to go to the You're expecting me to sit in front of a computer and go and zoom into the evidence? I don't have time for that. What would you say?
I would say the foundation for what we are doing is knowledge. And if you want to be professional, you need to use the tools that you have available. And this is not only like sitting on a computer. This could be on your mobile phone, in your pocket. I mean, we used the pocket books before. This is just so much quicker. It's just one search and you have the answer. Instead of disturbing your colleagues and say, oh, I don't know what to do in this situation, how do I do this? So if you really want to work smart, you need to use the tools that you have. So, and if you want to be professional, I mean, you need to know what to do, but you also need to understand why are you doing what you're doing and communicate that. You will never get respect from your other colleagues, from the doctors, from the authorities, from the managers, if you're not able to explain why you are doing what you're doing. So if we want to be taken serious, if we want to be professional, that's the way. And all of us have a responsibility to further educate. And this is a lifelong learning profession.
I really enjoyed that. Thank you very much. Is there interest from others, like AHPs, pharmacists, doctors, in using the same system?
Yeah. We see that, well, because the Norwegian Nurses Organization owned the system in the beginning, it was only for the nurses. But we now see that more and more other health professionals are using it, and also doctors. So we receive emails from doctors saying, this is the best system because you can argue so good. And I think that is one of the keys, that we can, the rationale for what we're doing, that is also what the doctors need. They don't have the time to do critical analysis of new research and get the essence out of it. We're doing that for the professions, and that saves a lot of time at all levels. We also have requests for more content for physiotherapists, for other professions in the system. And it's all about enough resources to do it, actually. Yeah.
And just another one. Does it influence workforce planning? You know, working out how many nurses do you need?
Yeah. And we have a collaboration with some vendors only focusing on that perspective in other countries, and it's interesting to see. I think we also need to do something on that side, because the systems are maybe too heavy to use today, because the nurses have to document all the steps that we, for example, have described in the procedure, has a key, has a value to it. But if you're going to document every step in a procedure, you see, it's too much work. So we also need to think more automatization, more on a group level, on a system level in those systems. But it definitely will define the quality, and the quality needs to be connected to what you're supposed to do and to a kind of number to say something about the resources that is needed.
I've got another question, if I may. Sorry to hog the microphone. So this is facing the nurse in the clinical environment. Is there a plan or a thinking about enabling patients or service users to have more information?
That is a good question. We have been talking about, or I have been thinking about that, because when I first twisted my brain to think patient perspective, it was hard to twist it back to the nurse's perspective. So I've been talking about that for years and years. But it takes consideration to build up a good system for that, to handle questions, etc., from patients and so on. So we are collaborating also with others, making system for patients that we can actually integrate, because one system can't do everything. That's why we need interoperability. That's why we need to connect systems with information flow across softwares and solutions. So I think we are going more and more in that direction, and that would be, we will see more of that in the future, and we will definitely go in that direction.
My turn now. I'm Katie McClure, Chair of BCS Health and Care Scotland, and previously I've done research around pharmacy practice. So I know that in Norway they use one system within the community pharmacies. Everyone uses it. And you spoke about having been able to get one system in VAR that's being used across nursing informatics and clearly is making an influence on people in other professions. We have a workforce policy in Scotland of Once for Scotland, and that's the strategy that's around. Are there lessons for us from what's been done in Norway around the systems that could then feed into the workforce, almost the workforce planning again, Christine, and how it's in use?
Yeah. Yeah, what can we learn? We can learn that when we talk about knowledge, there are many people owning the knowledge, but we need to share. So it could be like a tension in trying to build one system, just based on that. But if you build it up, if you prove that this is good, if you can show that this is a better way of going when it comes to spending resources, getting out to results, it's worth going in that direction. And collaboration, I think that is one of the most important things that we need to focus on. So we're not building up like, not enemies, because we're not enemies, but we want to go in one direction. If you set the goal of what you want, that's almost like the nursing process. There can be many ways to that goal, but at least you have the goal in sight. And it could be like you compete with two systems, but it's always like you have to choose the best one and you have to go in the same direction. And I think that is pretty much it. And challenge each other. It's that if you need to challenge each other on the quality, on the results, and not to mention, it's not only about science, it's how you merge science and the practical perspective together. Usability, usefulness, and so on, but really bring together the bright minds from all various types of professions, engineering, nurses from the floor who is experts, theoretical nurses, researchers, and so on. That's when you get the good results.
Okay, we have a question online.
Yeah.
And Kristen.
So the question's from Paula Proctor. Thank you. Hi, thank you for an excellent talk. My question, in Norway, is there any dilution of registered nurses? And if there is, does VAR offer different levels of instruction?
Yeah, good question, Paula. Good to have you online. We have, like, it's only bachelor education for nurses, but we also have a lower level consisting of 2 years of education for a lower level nurses. They also use the same system. It has been a discussion whether to customize it more to the lower level, but we have ended up in discussions throughout all these years. If you have one system for all, they can also see what has been done with the patient, for example, at the hospital, at the intensive care unit, when you receive the patient in a medical ward or at home, to understand what did the nurses do there and to get the continuity across not only settings but also professions. You have the possibility, though, in the system, we have used technology there, you can turn off a procedure if that is needed. Sometimes we have doctors saying, no, we use my procedure in this unit, and then you can do that for example, in a hospital, but you can also put in notes saying that undergraduates or helpers in a system cannot perform this procedure. So you can actually build that in for yourself. As long as we don't have one agreed system of who is doing what, we can't build that into a general system. You have to do that locally. But the possibility is there. Yeah.
Thanks for the comment on
One.
So I think, well, the first one's a comment, maybe the second was a question. So it's from Nick Hardiger. Thanks, Anne, for your insights. The development of nursing records is evolutionary in nature and we will continue to lurch from best attempt to best attempt, never quite hitting on the solution. This means that change is inevitable, and yet each change brings enormous upheaval in practice. How can we/you build the inevitability of change into our or your development processes?
Thank you, Nick, for that question. One person can't do, on one system can't do it all. And I try to do my best talking about it when I see possibilities, and I'm impatient because I want to see the system now. And finally, after years and years of talking about the possibilities and giving away my ideas to other companies who can earn money on it, that's okay, because I want to see the solution. I want a change here. I want us to take a bigger step because we have been struggling with the same thing. We see that the quality of the input in the electronic patient record system still needs to improve. I believe this is one way. It could be many ways, but this is what I see. And I think that we could actually challenge and collaborate better instead of competing. And that's what we're trying to do. In Norway, I talk with all the vendors. In Germany and Switzerland, I talk to them, I meet. I have been invited to meeting to talk about the ideas. But the change is slow. But you have to put the seeds in the ground and water them. And when you water them, it will flourish one day. And we need to join the forces and go in the same direction. So we need to educate each other. The engineers need to listen to us, and we need to listen to them to see the possibilities and co-work to make it happen, I think.
Thank you very much, Anne, Kristen. Just to summarise, that was really, really interesting. I could go on listening to the questions and hearing your thoughts. I think what strikes me is that you have described so well the important key elements of a change-ready, digital-ready culture in your comments about questioning, always questioning. And maybe we never will have the perfect system, but we'll keep improving by keep questioning and by collaborating with all those involved, particularly the nurses who are using the system. So really wonderful to see from your initial ideas through to how it's working in practice and supporting quality care and professional nursing care. So thank you very much, and thank you to the audience, and thank you very much to all those online for listening. Thank you.
Thank you. Thank you.
Excellent, thank you.
Thank you.